Okay guys, now we're going to go to the hypertensive disorders. You can watch these videos in any uh, order that you wish to watch them in. Uh, I'm just trying to do it in an area, in an order that you makes a little more sense to you, but it might make more sense to you to do it the other way. So just be sure you watch all of them. So off to hypertensive disorders. Okay, so hypertensive disorders in pregnancy. There are different classifications of hypertensive disorders in pregnancy. Some of them are when the patient has chronic hypertension to begin with, and that becomes chronic hypertension that's superimposed with preeclampsia. There's the gestational hypertension where they start getting hypertensive during their pregnancy, preeclampsia, eclampsia, and then part of the preeclampsia, eclampsia includes the HELP syndrome as well. So the gestational hypertension without proteinuria, you have to have proteinuria for it to be considered preeclampsia, usually is seen after the 20 weeks pregnancy. During that first trimester, remember we talked about how blood pressures would be low. So it's the most frequent cause of hypertension in pregnancy, and it can occur anytime after 20 weeks. A lot of times, though, it usually waits until 37 weeks of gestation for it to be. It takes about 6 weeks after giving birth to return to a normal blood pressure, previous blood pressure. And this may be an indication that your patient may have some problems with blood pressure that nobody recognized, and that the stress of the pregnancy could cause the blood pressure to start becoming high. Preeclampsia is definitely pregnancy specific, develops after 20 weeks, usually presents with hypertension, protein in the urine, and um, edema. So um, it usually is one of our highest contributors to having perinatal mortality and morbidity. Actually, what preeclampsia is not the blood pressure being high. It's actually a vasospastic systemic disorder that causes the blood pressure to be high. And we're going to look at both mild and severe cases of preeclampsia. Eclampsia is preeclampsia that has gone on and developed seizures. Then, of course, your chronic would be before the pregnancy or before 20 weeks of pregnancy. So, let's see what we can find out. Gestational, PIH is what most of us know it by, but they started calling it gestational. PIH being pregnancy-induced hypertension. We talked about after 20 weeks. To diagnose that, you must take a blood pressure 6 hours apart. Somebody comes in your office and they have hypertension, you need to take their blood pressure again to be sure it wasn't white coat syndrome, stress from sitting in the office too long, whatever. You need to take the blood pressure again in 6 hours to see if it is still high. 140/90 is your baseline consideration of hypertension. Um, you'll see an increased risk for C-sections with these patients. And again, they do not have protein in their urine. This is what determines the difference between it and your preeclampsia. So your preeclampsia is a bad thing, and it's in red because if you're preeclamptic, you are at high risk for hemorrhage. It can be mild or it can be severe. So mild preeclampsia is when the blood pressure is 140/90 or greater. Again, presents on 2 occasions, at least 4 to 6 hours apart. Protein in the urine at random samples should be at least 1 plus to 2 plus. Edema in the hands and the face and even in the abdomen, and a rapid weight gain is a real big indicator of preeclampsia. It can go from mild preeclampsia to severe preeclampsia. The systolic has to be 160 or greater, and the diastolic has to be 110 or greater. Your proteinuria, you'll have 5 grams in a 24-hour urine collection or greater than 3 plus on your dipstick. And oliguria also occurs with this. You'll have less than 400 milliliters of urine output in 24 hours. You'll also have quite a bit of visual disturbance and hepatic involvement in this. Anytime you have a patient that you're concerned with their blood pressure that complains about blurred vision, you need to have them come in, because usually blurred vision with blood pressure problems is an indication of preeclampsia and worsening preeclampsia. HELLP syndrome is a spin-off of preeclampsia, and basically hemolysis is your age, and that means you have a decreased hematocrit. Your E stands for elevated liver enzymes, that's your AST. And then low platelets, so there's your 2 L's, liver and low, and then your P, platelets. So low platelets are considered less than 100,000. So when you see less than 100,000 platelets and an increase in your liver enzymes and a decrease in your hematocrit, especially if your patient presents with upper epigastric pain, nausea, and vomiting, and a lot of times your vomiting will look like coffee grounds, this is a very big emergency. This patient needs to be delivered. So anytime you see any of these symptoms, you have gone from preeclamptic into HELLP syndrome, which is very bad. Preeclampsia is pretty bad, but HELLP syndrome is life-threatening. So eclampsia is a little different in that it's characterized by the development of seizures. So you have all of your preeclamptic signs and symptoms. Usually you go from the mild to the severe to the eclampsia. And the HELLP syndrome kind of occurs somewhere in between all of that. You're also going to have that decreased liver perfusion. You'll have positive clonus, which is when you pull the foot back and you release it, it continues to jerk all the way back to the proper position it's in. That's an impending sign of seizure. So you want to always check clonus on people that have preeclampsia. Always be sure you're checking your deep tendon reflexes. If they're greater than 3 plus, that's another impending sign of seizures. So you always want your deep tendon reflexes to be around 2 plus, and that's it. And if you've got them on mag sulfate, 1 plus is even okay. When they get down to 0, you need to be getting concerned that they may be becoming toxic with magnesium sulfate. So, how are we going to take care of these patients? This is the patients with preeclampsia, eclampsia, HELLP syndrome, gestational hypertension, all of these things, but the most important ones are the preeclampsia, eclampsia, and the HELLP syndrome. So we're going to make sure we're assessing all of our PIHers for edema and protein in the urine, because then they will become a preeclamptic patient. They will no longer be a PIH patient or a gestational hypertensive patient. Be sure we're assessing their vision. If they're having spots or blurred vision, we're having some severe preeclampsia going on. Headaches are a bad thing. Patient calls you, you've been concerned about her blood pressure, and she calls and tells you she's been having a severe headache with blurred vision. Would you see her or would you not? Of course you would. You wouldn't tell her take an aspirin and go to bed. Be sure we're doing those deep tendon reflexes and clonus. When we give our mag sulfate, we are not giving the mag sulfate to treat the blood pressure. We are giving the magnesium sulfate to prevent seizures from occurring. So we want to be seeing, we're going to have to be checking in the deep tendon reflexes, because we could also develop, not only could we have hypertonic tonicity, we could also have hypo. So we want to be sure that we are walking that fine line between magnesium being therapeutic and magnesium being toxic. What would you think you would see on a fetal monitor strip with preeclampsia and eclampsia? Well, it's a constricting type disease, right? Vasospastic. It's systemic, so that means that we're going to have constricted vessels that are feeding the placenta. The placenta itself will be having a constricted development because of the way that the patient has developed her nutritional flow to the placenta. So is there going to be enough placental flow for the baby to get adequate nutrition and adequate oxygen? Probably not. So every time this patient is placed on the monitor, we're probably going to see if she's having chest half contractions for us to be able to call them late decelerations, right? So we're going to be seeing decelerations, and depending on whether or not she's in labor, whether we can name them as late decelerations or prolonged decelerations. Prolonged decelerations are just those decelerations that last for more than 2 minutes, regardless of whether or not there is a contraction. But usually we will see decreased variability and an increase in decelerations in these patients. If they do happen to go into a seizure, our baby is definitely not getting oxygen supply. We never ever want to leave that seizing patient alone. If we can, we'd like to turn her on her left side, but you cannot restrain her in any form or fashion. She may do more harm to herself. We just want to try to stay with her to be sure she doesn't swallow her tongue. We want to, if we have a patient who is eclamptic or preeclamptic, they should be provided a really quiet, dark room, lots of bed rest. They should have TED hose or CSDs on to prevent them from having emboli, because this is they're very high risk for developing that, especially with their abdomen being so large and being on bed rest and then having this disease process as well. We usually do not limit the salt intake because it's not salt intake that's causing them to have hypertension, a preeclampsia. We do need to do daily weights. If we have severe preeclampsia, we insert a Foley that has a metered reader on it so that we can do hourly I&O. We need to start magnesium sulfate. When we have a patient that's on magnesium sulfate, urine output will become minimum. We will hopefully still get our 30 per hour, and it will be kind of a dark amber color. If you're not seeing a dark amber color, then your kidneys are not processing the magnesium sulfate out. And if it's not processing the magnesium sulfate out, what's going to happen to our patient? And our patient's going to develop a magnesium toxicity. So we have to be very careful monitoring these patients. This is a one-on-one patient, one nurse, one patient, and they will have no other patients with this one because they're such a high risk. Of course, really there's 2 patients in there that we are monitoring and watching. So this is how we take care of our patients during magnesium sulfate infusion. First of all, of course, our doctor has to order a magnesium sulfate. And we first give a loading dose, and then we give a maintenance dose. But before we start any of this mag sulfate, we have to prepare the patient for it, especially if they've never had it before. They're going to feel flushed and hot. I show caring by bringing a fan in before I start my magnesium sulfate, because I know my patient's going to need that, and I want her to have that comfort. So she will also have sweating with this. She'll feel weak, and I like to tell my patients, you'll be feeling like you got run over by a Mack truck. That loading dose of 4 to 6 grams has to be given over 15 to 30 minutes, and then we do a maintenance dose of 1 to 3 grams, and it's usually at 2 grams, and it goes up if we still have problems with deep tendons being hypertonic. And how do we know that our magnesium sulfate's working? Well, what are we giving it for? We're giving it to prevent seizures. So how do we know it's working? We're not having any seizures. So that's how that works. We need to do fetal heart tones, deep tendon reflexes, and vital signs every 15 to 30 minutes. During the first part of the infusion, some facilities will decrease that to hourly after so many hours of being on the magnesium sulfate. But the patient still has to be a one-on-one patient, because given mag sulfate is very dangerous in itself. So our intake and our output. Our intake, I've already told you the output should be at least 30, but it'll probably be minimum with your magnesium sulfate with an amber urine. Your intake should not exceed 125 mils per hour. So this means if you've got your mag sulfate's running at 25 mils or 50 mils an hour, then your main IV line has to run at 75 or 100. So you can't exceed more than 125. You don't worry about PO because you don't give them PO. You might let them have ice chips, but you don't give them PO. Magnesium and calcium levels should be done. Most uh, hospitals have a policy that says that mag and calcium levels should be drawn every so often while patients on magnesium. Uh, However, there has been a new school of thought that if they're symptomatic, then we should have a mag and calcium level drawn. But if they're not symptomatic, then we should not have to have our patients have an invasive procedure done. So it depends on your doctor and the hospital policy as to which they do. But usually when you're doing, why are we doing calcium levels? Because the magnesium is displacing the calcium, and the calcium's going um, out of the vascular system into those interstitial spaces. Therapeutic level is what we would consider high on a patient that was not pregnant. And the therapeutic level can range anywhere from 4 to 8. You have to use your own judgment as to whether, someone that's got a 5 therapeutic level may actually be showing toxicity. They may be having respiratory rate of less than 12. They may be having a decrease in level of consciousness. Deep tendons may be decreased, and the other patient in the other room may have a therapeutic level of 8 and not showing any signs of toxicity. So you have to know what to look for. Calcium gluconate is going to be your antidote to your mag sulfate. Should have it always immediately available. Usually most of your OB units have what they call a mag bag that they keep a reflex hammer in, calcium gluconate, and they used to keep Valium in them in case they had a seizure and the mag sulfate wasn't working when they gave a bolus in. So they don't keep the Valium in anymore because it's such a high scheduled drug, but they do keep calcium gluconate. You give up to a gram of calcium gluconate, and what you do is you titrate it in. You're going to stop your mag, and you're going to titrate your calcium gluconate up to 1 gram until the symptoms have resolved and your patient is back to being normal. What we do to treat the hypertension of preeclampsia is we give hydralazine or presaline for blood pressures that are 160 or greater systolic or 110 or greater diastolic. So remember, mag sulfate for seizures, hydralazine or presaline for those high blood pressures. After the baby's born, hopefully we will get that baby delivered with no problems to the baby, but there's always going to be a chance there's problems with the baby because of the vasospasms that have occurred. The baby may be IUGR, the baby may have respiratory issues, especially if they've been on mag sulfate therapy for quite some time. It passes over into the placenta and it decreases the baby's respiratory effort as well, so we may have to do resuscitation of the baby and keep him in the nursery for a while. But with our mom at postpartum care, symptoms of preeclampsia should resolve within 48 hours because the cause of it was the pregnancy. The pregnancy is now over. We should continue with our mag sulfate for at least 12 to 24 hours after delivery because they can have seizures after delivery. In fact, they can actually develop postpartum preeclampsia and a week or two after they've delivered. So we really need to keep a close eye on these patients. They're at very high risk for hemorrhage because of the state of their hypertension and the vasospastic um, systematic changes that we see with preeclampsia. We should never give ergotrate or methotrexate with a preeclamptic patient. We can give hemabate, but Pitocin, oxytocin should always be our first line of defense. So you should always give Pitocin instead of ergotrate or methotrexate. Um, and hemabate. You should always give oxytocin first. Then we could give hemabate if we absolutely had to. You don't like to give any type of constricting drugs that's going to constrict vessels because you've already got the problem of preeclampsia going on. You're going to administer narcotics with caution, especially during the phase that you're having magnesium sulfate run. And they can also, like I said, develop that. And remember, when we're taking care of our patients, we have to watch for signs and symptoms of toxicity, and that's going to be respirations to less than 12, a decrease in the level of consciousness, decrease in deep tendon reflexes, and these are things that we need to call the doctor for. And you should immediately stop that mag. You should administer the calcium gluconate and, of course, notify your physician. But don't forget to take your mag off, because you won't be doing yourself any good if you don't stop the mag. Of course, our infant is at risk, like I said, for respiratory depression. So be sure that you are ready with any patient on MAG, that you've got your bag and mask out and ready to do resuscitation. MAG sulfate's been known to increase bilirubin in a baby, so we got to watch for jaundice. Of course, the baby's going to have really poor muscle tone because he's getting MAG sulfate doing all that smooth muscle relaxation. So we're not going to have a really good first APGAR. May not even have a good second APGAR because of the MAG sulfate. The preeclampsia will cause them to have intrauterine growth restriction, and they may develop difficulty eating, suck and swallow, because of the MAG sulfate. Never ever do a vaginal exam on a bleeding pregnant woman. Can't say that enough and mean it. We have two different types of bleeding that we're looking at in our hypertensive disorders. And this is the abruptio and the placenta previa. And I know you've heard me mention placenta previa and abruptio several times. But that's been a semester ago. A whole semester ago. So the placenta previa, it presents as bright, painless vaginal bleeding. It is caused by the placenta implanting at or over that cervical os. It occurs after 24 weeks. We can't diagnose it before 24 weeks because the baby's not viable, and the placenta can move anytime. As the uterus grows bigger, it can pull the placenta up with it and actually not be there after 24 weeks. After the 24 weeks has occurred, then the placenta is pretty much where it's going to be and won't change. We have total, which is completely covering the os. We have partial, which partially occludes the os, and neither one of these can be vag delivered. The marginal, depending on how marginal it is, can vag deliver. Regardless, hemorrhage is going to be one of our big things that we're looking for, because the placenta is coming loose. The more the cervix is opening, the more the bleeding is going to occur. The major difference between telling the abruptio placenta from the placenta previa is usually painless. The stomach is soft. There's no hard contractions. There's nothing in there that's going to be painful for her. Abruptio placenta, on the other hand, is premature separation of part or all of that placenta away from the uterine wall. We can have a complete abruption that can be concealed or not concealed. We might see a massive amount of vaginal bleeding, or we may see no vaginal bleeding and still have a complete abruptio placenta. The first abruptio placenta I had, the doctor came in, did ultrasound, and still couldn't tell it was abruptio. But I knew it was an abruptio because of all the blood that was running down her legs, the big liver-sized clots in her shoes. Her abdomen was extremely hard, and she was in severe pain. So what we will normally see with abruptio placenta is a sinusoidal pattern. If you don't know what that sinusoidal pattern is, be sure and look it up in your fetal monitoring. That's the one that looks like the check mark, and it's usually because the baby is becoming anemic because of loss of blood somewhere, or ABO, RH incompatibility, or ABO incompatibility. Something is causing the baby to be anemic. The bleeding, on the other hand, is usually dark, whereas it's bright red with the previa. There's going to be really strong contractions. Abruptio placenta can be the result of preeclampsia. It can also be the result of cocaine. It can be the result of blunt force trauma to the abdomen. And even smoking can cause a patient to have abruptio placenta. These are things that you really need to be watched for. You may not see any fetal distress with the placenta previa, but you're going to see a whole lot of stress with the abruptio. It depends on how much bleeding has occurred with the placenta previa. An incompetent cervix. Premature dilation of the cervix. Most common cause of late trimester loss. And basically this is just the cervix, in the absence of uterine contractions, just dilates on its own and actually becomes complete enough for a fetus to pass through. So if you're only, like, say 20 weeks and your cervix is open to 3 to 4 centimeters, the baby can slip through that. Usually to treat incompetent cervix, we can do some management, with bed rest, hydration, tocolytics. But the best thing to do is to try to get a cerclage placed at about 12 to 14 weeks. And most doctors won't place a cerclage until your cervix has been incompetent and you've had one fetal loss through incompetent cervix. Then they go in and will put the McDonald cerclage in at 12 to 14 weeks. Anytime we go in and mess with anything that's doing with our carriage here, we take risks for premature rupture of membranes, preterm labor, and even chorioamnioitis, because we're messing around where we don't belong. However, it will help hold the baby in. When the mom starts having contractions and it's time for her to deliver, when she comes in, we have to make sure the cerclage is removed. Usually the doctor does that because it's been put in surgically. It needs to be removed. It's almost like a shoelace that's just been woven through the cervix and pulled tight and tied. They can actually choose to leave it in and have a C-section and be able to have a couple more babies with the same cerclage. But most people would prefer to take out the cerclage and do vaginal delivery. It usually won't take very long because the cervix is so incompetent that usually not long after you take out the cerclage, the delivery occurs. I'm going to stop here because I'm afraid I won't be able to get it all done.